Good evening, everyone. Thank you for bearing with us and being so patient. I'm really sorry about the delay, and particular apologies to Professor Vasdev, who has been fabulous this evening in trying to get to us a little bit later than we planned, but earlier than he thought we were expecting him. So sincere apologies for that, but really looking forward to a great presentation from Professor Vasdev today. So this is the next one of our series of men's health webinars that we've been running from Hitchin and Whitwell Primary Care Network. My name is Tara Belcher. I'm a GP in Hitchin, and I'm also the clinical director of Hitchin and Whitwell Primary Care Network. Tonight, we're really lucky to have Professor Nikhil Vasdev with us, who's going to talk about urological health in men. Our plan is to have a 30 to 35-minute presentation, and then there'll be time for questions. Because of the way that our Teams meeting is formatted, you won't be able to actually speak to us, but if you pop anything that you want to ask in the chat or the Q&A box, myself and my manager, Dion, will be keeping an eye on that. And then at the end, we'll make sure that as many questions as possible are answered. So Prof. Vasdev will be able to give you lots of general information about urological health, but we wouldn't expect him to answer individual questions that were personal to you yourself. I'd also like to thank Pine Hill Hospital for facilitating Prof. Vasdev being with us this evening. And I was hoping that we'd be able to hand over to Jackie, who's the business relations manager from Port Mill Surgery. The business relations manager from Pine Hill Hospital, to tell you a little bit about the services they offer. But I think she's struggling to get online. Oh, she's just joined us. So hopefully Jackie will be able to tell us a little bit about the services that are on offer at Pine Hill before we hand over to Prof. Vasdev. And apologies for everything being a little bit clunky this evening compared to usual.
Good evening, Dr. Belcher. Apologies for not being able to log in then, and thank you for the link, Dion. Good evening, everybody. I'd like to thank Dr. Belcher and Dion, the rest of the team at Hitchin and Whitwell Primary Care Network for inviting a Pine Hill consultant to speak to you all at the Men's Health webinar. And apologies that we're a little bit delayed this evening. Can you hear me okay, Dr. Belcher?
Absolutely, yes. Thanks,
Okay.
Jackie.
So for those of you that are unaware who I am, I'm the Business Relations Manager at Pine Hill. And just to remind you all, Pine Hill Hospital is part of Ramsay Healthcare UK, so one of the major independent healthcare providers in England. Pine Hill Hospital is one of Hertfordshire's leading private hospitals with an excellent reputation for delivering high quality healthcare for patients with health insurance, patients who are self-funding, or NHS patients exercising choice through the ERS system. By investing in the latest advanced medical technology, and you'll be hearing a lot about that from Professor Vasdev very shortly, we do offer faster access to a wide range of treatments and services such as orthopedics, women's health, men's health, eye care, and I can go on, including diagnostics, which currently we're looking at about a wait time of 1 to 3 days for private MRI or CTs. If you do have medical insurance or are self-paying and you're unsure about how to access private healthcare at Pine Hill, you can discuss flexible finance options at Pine Hill Hospital with our private patient team on 01462 427 227. And if you'd like more information about accessing private healthcare, you can also contact me. We're also very aware that lots of people can't afford private healthcare during the cost of living crisis at the moment, and we do actually offer quite a lot of NHS clinics at Pine Hill Hospital as well, ranging from general surgery such as hernias, gallbladders, to direct access endoscopy, as well as our NHS aquablation clinic, which you'll hear about from Professor Vasdev very shortly. Most of our clinics have a very minimal wait time, looking at about 3 days to a couple of weeks, sometimes 6 weeks at the most. And I just wanted to highlight that for any NHS patients coming to Pine Hill Hospital, there are a lot more guidelines there, and all NHS patients must be referred via your GP, such as Dr. Tara Belcher. And I'm afraid all BMI must be under 40 and preferably not with multiple comorbidities, just meaning without multiple health issues, as these kind of patients are still better managed at the local trust hospital. If you have any questions about any of the NHS services at Pine Hill, please contact our NHS team on 01462 427 218. At Pine Hill Hospital, we are also very proud to be in partnership, one of the most qualified and experienced consultants in the UK. And on that note, I will pass you over to Professor Nikhil Vasdev, our fantastic consultant, urological and robotic surgeon, who will be updating you on prostate cancer or benign prostate hyperplasia, and why it is so important to be aware of the symptoms.
Well,
Thank you,
thank you.
Jackie. Thank you.
Excellent. I hope you can hear me.
Perfectly.
So good evening, Tara and Jackie. Thank you for the introduction. I'm just going to start off by sharing my screen. That's the first hurdle amongst most presentations, and I hope you can see my screen now. Hope you can see that.
Yep, we can see that, and it's in slideshow mode, I think. So that's great. Thank you.
Perfect. So, ladies and gentlemen, it's a real pleasure to talk to you about men's health in 2026. There's a lot which is happening, and sort of working out of Pine Hill, I specialize in prostate diagnostics, prostate cancer, benign prostatic hyperplasia. But I think, men's health is something which we probably need to focus a little bit more on in the context of what's happening. So prostate cancer awareness, it's not uncommon that you switch on your news channel or you switch on, you go to a service station or you have a look at something on social media and the awareness around PSA and prostate cancer comes up. So I thought I would take a couple of minutes tonight to put a presentation together, basically to cover the array of men's health issues which are coming up and what we can do certainly to improve survival in our patients. So I think the real question which comes up a lot is the prostate. So what is the prostate gland? What does it do? What happens when patients have prostate cancer surgery done? What impact does it have? So the prostate essentially is a gland which sits just below the bladder. And the water pipe, which is called the urethra, passes through it. So this is a nice anatomical description of the bladder. You can see the bladder is nice and concentric and round. And the two eyes that you see up here are the tubes that come down from the bladder, from the kidney to the bladder, called the ureter. So urine comes down, and the bladder is a storage organ. And the main role of the prostate is not so much to do with continence, but it's a lot to do with the maturity of semen. So the prostate's main role is to mature semen and provide a lot of nutrition. So it's a gland that, as a man gets older, the gland grows in size. So this is what we tend to see when patients complain about a lot of symptoms when they can't pee properly, they're waking up more often at night. And a lot of the time patients come and get a little bit concerned to say that, is this related to cancer or is this related to benign prostatic hyperplasia, which is a non-cancerous enlargement of the prostate? And we as urologists certainly can do specific tests to find out the difference between a cancerous prostate versus an enlarged prostate, which happens as patients get older. Now, the other surprising part of the prostate gland is that size doesn't matter. So we may have patients who have small prostates who have a lot of symptoms, and we may have patients who have enormous prostates who are walking around the high street with no symptoms whatsoever. So size is important to guide treatment, but purely a size being picked up on an ultrasound scan, if someone goes for a scan of the liver, of the abdomen, for example, because of pain, and they pick up a big prostate, it doesn't mean that they require treatment necessarily. And I'll sort of delve into that fairly shortly. So there's a lot of debate which happens with prostate cancer. And, Sir Chris Hoy is one of the most acclaimed international athletes that all of us know of. And despite of him complaining about shoulder pain for a couple of months and having every test under the sun that was picked up, no one sort of really checked him up until pretty advanced when his symptoms were getting worse, that he had prostate cancer, which was so advanced that it spread throughout the system. So that's the reason why there's a lot of push to take place and highlight the fact that if prostate cancer, just like any other cancer, if it's picked up early and treated in an appropriate manner, if it's picked up at an early stage, it is associated with a very favorable outcome. Whereas when it's picked up in a more advanced stage, the outcome may not be as favorable. So there's a big push taking place on screening. That means we have a breast screening program. Ladies have breast screening, cervical screening programs. But for prostate right now, we're still working on a little bit more in the context of what population of patients we should screen. And I'll just sort of give you a broad perspective of this because I sit on the National Clinical Advisory Group for Prostate Cancer UK, and where we come up with a lot of guidelines which help to what we do in our clinical practice at the minute. So I've written a few blogs. I was in the BBC a couple of weeks ago. I've written something in the Telegraph. If that interests you, you can just sort of download these online on some of the questions which come up. But certainly prostate cancer now is sort of being picked up a lot quicker than what it was before. But the amount of prostate cancer patients that are being picked up per year is about 12,000 to 15,000 patients are diagnosed. But despite of that, despite the high diagnosis, we still have patients who have issues with death from prostate cancer, especially when it's advanced, when it's spread to the bones and the lymph nodes. And this is why there's a huge project running in the UK right now in which we're trying to look to see how we can improve survival in patients. And this is something being run by prostate cancer. So screening for the moment is not happening, but I can reassure you it will happen. We're doing a lot of work behind the scenes to evaluate this, and we are using some newer technologies such as MRI, some blood tests, some biomarkers, which are basically signatures of cancers in someone's circulation to pick up. And we're going to transform prostate cancer care, and that's what the trial stands for. So you might have read about or heard about this trial, but this is currently recruiting patients, and we want to recruit about 300,000 men in the UK to really get an answer with screening per se. There's a lot of genetic predisposition with prostate cancer. So a lot of the time you have patients who have prostate cancer and, they'll come and say, doctor, my waterworks symptoms have changed a bit. My grandfather, who was in their 80s, had prostate cancer. Do I have the risk of developing prostate cancer? Now, prostate cancer, as men get older, the risk increases, and I'll share some data with you on the risk increase which takes place. But now the definition of hereditary prostate cancer is when a first-degree relative, so your brother or your father, have had a prostate cancer diagnosis below the age of 55. So, this is where we have a strong genetic relationship where a young relative has been diagnosed with prostate cancer as against someone who's 80, 90, or 100 who's been diagnosed with prostate cancer later on. So when you look at the landscape of prostate cancer at the minute, the risk of any man in the UK developing prostate cancer is 1 in 8. So this is the normal population. You can see that about 52,000 patients are diagnosed per year with the advent. Obviously, during COVID, we saw a big drop, but now we've seen a rise. But about 10,000 men die from prostate cancer each year. And this is where the screening program really is zoning in how we can reduce the particular mortality associated with prostate cancer. This is the age-specific data. This is 2017 data, but this hasn't really changed much on the 2023 demographics, in which the peak age of prostate cancer diagnosis is about 65 to 70. This is where the diagnosis peaks. And you can see as patients get older, you can also have prostate cancer picked up. So the youngest patient I have done robotic prostate cancer surgery on was 32, but they had a strong family history of prostate cancer. That's how they were diagnosed very, very young in their late 30s for prostate cancer. So who's at risk? I think any patient above the age of 50 or patients who are getting older, this increases the risk. And there's a lot of clear-cut guidelines available on blood tests. We use a lot of terminology called the PSA level. You have bodies which offer free PSA tests. You can see your GPs and discuss the PSA tests. And I'll tell you very quickly about PSA tests, because PSA stands for prostate-specific antigen. This is not specific for prostate cancer-specific antigen. So it's a PSA essentially is an enzyme which is present in the prostate to keep the semen in a semi-liquid form. That's what PSA does. But it can go up in a lot of conditions, and I'll share some conditions which include infections when the prostate gets larger in size. So as the prostate grows larger in size, it produces more PSA, or in prostate cancer, of course, and in some patients who have had prostatitis or infections and so on. This is a sort of pathway that we tend to do when patients get referred to us to our specialty. So, you come and see us in the NHS or in the private sector. We just basically organize certain specific investigations, which I'll touch upon about what we're doing with a lot of stuff. But something new, which is also coming up, which is of great interest, is the examination of the prostate, a digital rectal examination, accurate? Is it a good test? So this is something that we just wrote and published. I was a co-author on this from Prostate Cancer UK to say, with the advent of time and innovation, the MRI scan is quite accurate in a good way to tell us what's happening within the prostate. So it can give us the size of the prostate. It can give us signals if there's something sitting or hiding within the prostate. Because as you can imagine, if I examine someone's prostate from the back passage, I only feel the outer part of the prostate. I don't know what's happening within it. Whereas an MRI picks up exactly what's going on within the prostate. So this is where things are going to change as time moves on, in which with MRI accessibility, there's a lot of work taking place with MRIs and some biomarker work in which MRI capacity will increase, especially when we do include more and more screening as time moves on. So I want to share with you some patient stories so that, these are common stories which come up in the clinic. So I thought I would share with you what we do, just to give you a brief account on how things work out. So I saw this patient, and he was 52. He's an engineer. His wife's quite young. He's 46 compared to him. And he got a call from his brother who lives in Barbados and said that, he'd been diagnosed with prostate cancer. So this patient obviously got a little bit stressed. He started sort of noticing that he's waking up once or twice at night. His urine flow is not as strong as what it used to be in its 30s. And a common question which comes up is, does this patient have the risk of developing prostate cancer? Does he have prostate cancer at the minute? And what is the PSA? And that's something which I've just sort of discussed with you about the enzyme. Now, it's quite interesting to see that when you subdivide the population, patients from the Afro-Caribbean background, the normal population risk is about 1 in 8, whereas in Afro-Caribbean gentlemen, it's about 1 in 4. So the risk of developing prostate cancer is virtually double when you compare it to the standard population. And especially when someone's first-degree relatives have had prostate cancer, there's even a higher risk associated. Now, what's coming to light, which is very, very interesting based on latest data in 2026, is that obviously we talk a lot about prostate cancer, but now we are finding a strong link if there's a family history of breast cancer too, especially in younger family members. So if someone's sister has had breast cancer at a young age or even later on in life, and there's an associated mutation, something called the BRCA mutation, which some of you might have heard of, there is association now with the family history. So when patients come and see us, or we'll go across the Port Mill, we will not only take a family history of prostate cancer, we will also take a history to see if there's a family history of breast cancer, because it's a direct correlation between both tumors now as time has moved on. The PSA blood test, is it accurate? It can obviously go up in a lot of conditions. Some patients, I always tell them to sort of abstain from intercourse, cycling, prior to having the blood test done. But some patients do ask that if my prostate was examined by the GP or by a specialist, can that cause the PSA to go up? It can go up only marginally by about 0.5, but it really doesn't have a big impact. So, but these different conditions cause the PSA blood test to sort of rise up per se. As time will move on, and as in more and more guidelines come up, our European academic partners, the European Parliament is pushing very, very hard for a screening program, especially in countries like France and Belgium. And they have included some guidelines as to when a patient should have a PSA level done. This will follow through in due course. But having a baseline PSA at the age of 50 is not a bad thing to do. It can give you a lot of information, especially if the blood test is high for the threshold, but it can also predict if there's a risk of developing prostate cancer later on in life. And there's some more and more newer parameters coming out. But patients who are of Afro-Caribbean heritage, when there's a family history of a young member having prostate cancer, or certainly in those patients who have a family history of breast cancer with a first-degree relative, this is a cohort of population where we will be zoning in to really take into account this risk group where we will propagate PSA testing in the future as time moves on. But those of you who have some of these risk factors should have a baseline PSA done, especially if you're more than 50 years old. So this particular patient, just to sort of set the stream as to what goes on. So this particular patient had a blood test done. It was quite high for his age. And I examined his prostate. I felt that the prostate didn't feel quite right. So what we do is we do a MRI. I am the editor for Urology and Grey's Anatomy coming out next year in 2026 internationally. And we've included a lot of AI into the mix. So AI, as you're aware, is here to stay. And this is some of the work that we're doing in which we're looking at AI to give us a signal for cancer outcomes. So you can actually pick up some signaling based on MRIs. So the question is, where we see the particular lesion in question on the MRI, and we do very, very advanced MRI scans at Pine Hill. We do a lot of quality control with these because an MRI has a very, very high accuracy of 90%. And once we pick it up, this is what we tend to do is with the 3D modeling. This is obviously research right now that I'm leading in the country. But the modeling which is happening allows us to take some very precise biopsies of the prostate, which are done either when a patient's awake or asleep. The main side effects of a biopsy are obviously pain and discomfort. And sometimes there's a risk that patients may see blood in the urine, blood in the semen for a good couple of weeks afterwards. And there's a 1% risk that they may not be able to pee pass urine straight away after the biopsy. So there's some risk associated. So this is our data, and that's me up there. And Charlotte Foley, who's a colleague of mine at Pine Hill, who I work very closely with, to show that this advanced biopsy has a 95% accuracy to pick up cancer when put together with the MRI. So, we offer that here and we really, really pick it up. When a patient is diagnosed with prostate cancer, there are obviously different treatment options available. Something which I specialize in doing is robotic keyhole surgery. That is obviously for patients who come to see me here, but I do them at the Lister. I've done close to 1,400 of these. I did 2 today. I'm doing 2 tomorrow and 2 on Saturday. So plenty of robotic prostate work going on. But this particular technique that I do allows patients to have their nerves spared around the prostate without taking any compromise to their cancer control. So there's a lot of superiority with outcomes in these patients in which we cure their cancers whilst minimizing their side effects of incontinence and erectile function. So a lot of unique work taking place. There's some new types of radiotherapy which are out there, which we offer. But something which is new that we are developing, this is from my lab at the University of Hertfordshire, where we've developed a urine test to potentially pick up prostate cancer. So this is something that we've just published, and we are working towards doing some more validation work. So as time moves on, there may be a landscape moment where we do an MRI and we do a urine test as against an invasive biopsy. So that may be in the next 4 or 5 years on the horizon with AI thrown into the mix. So I'll sort of put a pause on cancer and just have a quick sip of water before I dive into enlarged prostates and what we do up at Pine Hill to help patients out. Now, as a patient gets older, the prostate gets larger in size. And there are certain complications which can happen when a prostate grows larger in size. This includes not being able to pass urine at all, going into retention, requiring a catheter. But other complications can also happen, such as infections, bleeding, kidney failure, and so on. For the past 2 years, with the support of Jackie, the team, Duncan at Pine Hill, we started one of the first procedures in the country called aqua ablation. So I'll just play this video and let it run for a second just for you to absorb what's going on. So what I want to show you in this video is this is the prostate, and I'm using a water jet to cut the prostate, to deal with the prostate. And you can see the moment I finish doing the aqua ablation, which is essentially using state-of-the-art robotic treatment to treat enlarged prostates, we on the table can get the patient to pee. So there's a very high success rate. I just sort of completed 125 procedures up here now. And this is what the prostate looks like. It obviously gets larger. As you can see, these are the sort of prostates we deal with. But the main role of aqua ablation is that it uses AI to cut the prostate with a high power jet.
You're on mute, Prof. Vasdev. I'm not sure if you know. I'm just going to see whether I can unmute you, Professor Vasdev, because you're on mute at the moment. No, I can't unmute you, so can you hear me? Jackie, I don't know whether you're in the same building as Prof. Vasdev, because I think maybe he's having some technical problems. Hopefully we can get those sorted out, because I'm sure you're all as interested as I am with this.
You're on mute.
Oh,
Sorry, can you hear me?
yes, now we can hear you. Good.
I was talking to myself for about 5 minutes, I think. So, sorry. So the aqua ablation uses the water jet to cut the prostate. And normally, if I take about 2 hours to cut a very large prostate, this cuts it in about 8 minutes' time. So there's a huge ergonomic benefit in patients having this procedure done. And if you look down here, what I tend to offer to patients at Pine Hill is a technology which reduces the chance of incontinence significantly. So normally, with traditional prostate surgery, incontinence risk is about 20%. With aqua ablation, it's 1%. And I can preserve key structures to preserve ejaculation and sexual function. So if you look down here, this is a preservation of the ejaculatory sphincter when I'm performing the aqua ablation on patients. The other real advantage is it's real time. So this is how it works. It uses the water jet to cut the prostate, so there's no heat. So there's no chance of collateral damage to tissue, such as the nerves around the prostate. So these are the nerve plexuses which sit around. So there's a huge, huge benefit. Yes, on Tuesday, I did 3 patients. The youngest patient who came to me was 44. because he really wanted to ensure that he had treatment for an enlarged prostate without ejaculatory or erectile function or incontinence-related issues. And this technology really, really benefits patients significantly. We get them home the next day, and they sort of come back to have their catheters taken out 3-4 days later. The other main advantage is this is what it looks like. So if you look on top, this is an enlarged prostate there. And using the AI, I am mapping out the prostate. So normally with traditional technology, if I would take about an hour to do this, this took 3.5 minutes to do with the AI. So there's a lot of advantages to patients, shorter operating time, less incontinence, lots and lots of preservation of ejaculatory and sexual function. So this is state-of-the-art treatment we offer up here at Pine Hill. And this is just some data which I put together just to project to the viewers tonight. This is state-of-the-art data on 70,000 patients that I've got ready. And essentially, you can see that, there's a very, very small chance of incontinence. It's 0.2% in 70,000 patients, because this treatment has been expanded rapidly worldwide as time has moved on. So really proud that we were the third adapters of aqua ablation in the country in Hitchin at Pine Hill. And we certainly have a lot of patients who come to us for this state-of-the-art treatment. So this is what it looks like when the patient's operation is finished. It's quite nice and clear. This is the catheter, and patients do really, really well. And, obviously, I go on auditing my data because it's a new procedure, but it's sort of nice, approved, and available both to private and NHS patients at Pine Hill. And we have a lot of men really benefiting from this state-of-the-art technology locally. So I'll sort of pause with that and take any questions. Thank you very much for the opportunity.
Thank you so much. What an interesting discussion. Lots of things I didn't, several things I didn't know there. I didn't know about the breast cancer link, and that's definitely something I'll be taking into my practice. I think it is really difficult in primary care because there isn't a screening programme, and when people are asking for PSA tests, usually we just do go ahead and do them. But I guess as for men understanding that the test isn't a be all and end all, if the PSA is raised, as you say, there are several reasons why that could be. I'm not sure I can't believe it, but we don't actually have many questions. So there is one question in the chat, which is, what is the performance value of 0? I think that was relating to one of your earlier slides. I don't quite know what that was. And I think I have a question which is probably helpful for me as a GP, but also maybe helpful for patients. So you were saying that perhaps it's not a bad idea if you're over 50 to have a sort of a baseline test. And certainly if you go onto Prostate Cancer UK website, if you're over 50, it will suggest that you are at higher risk. But then if that number comes back nice and low, at what point would you think it's sensible to get it retested?
So there are different guidelines available on this, which we are getting ready based on longitudinal data about how often someone should have a rebiopsy or how often they should have a PSA level done. Basically, the rule of thumb is about 4 to 8 years if the PSA is less than 1. And the interesting part about the whole thing is that if someone has a PSA of less than 1 at the age of 60, it's very unlikely that they will develop prostate cancer in their lifespan. So that's what it looks like so far. The only question is, you have some tumors which don't produce a PSA. That is the main concern. So you can have, although we have these thresholds, and now we are saying do an MRI instead of examining the prostate, where does the threshold stand? Because as it is in a health system that is pushed to its brink, now we're bringing an MRI in to do for everyone. So we're now talking about the use of something called micro ultrasound on the screening tool program, which gives you a little bit of a micro coefficient of contrast and dye, which we give during an MRI scan to pick up if there are areas of abnormality. So I think there's, AI will certainly transform the screening belt. That's what we have in the Transform trial. There's a lot of AI thrown into the mix. But, we'll help and guide you. But if a man comes across and he's 50, there's a family history of prostate cancer, family history of breast cancer, I think they should be offered a PSA.
Patient absolutely. And to be honest,
if a patient doesn't have any risk factors, then you can have a chat with them. But on the whole, the other interesting aspect is that if you sort of leave the cancer story aside with the PSA, a PSA is also quite a good biomarker to tell us what's happening within the prostate. So if someone's PSA is more than 1.4, they have symptoms, and their prostate volume is more than 30 cc. This is all sort of, stuff that we've developed as time has moved on. They will benefit from medication. Whereas if someone's PSA is less than 1.4, their prostates are 20 cc, they don't need to worry about anything at all, because they will never progress to develop the consequences and the complications of a benign prostate. So I think a PSA is a good baseline marker, but like you rightly said, the main concern is that it has other conditions in the prostate, because it's prostate specific, but not prostate cancer specific. That is a hassle. So you have a test which is available, which is cheap to do compared to a lot of the other biomarkers which happen. But on the other hand, we still do not have a consensus, whereas the United States and Europe, United States has a screening program. Europe is pushing very much ahead to do a screening program, which will happen imminently. Whereas we are still debating, but we still have 10,000 men who die from prostate cancer each year. So the question is, what is the balance? And it's all down to ensuring that, especially with the high-risk population, Afro-Caribbean gentlemen, family history of prostate cancer, family history of breast cancer, these patients are really pushed forward to have a PSA and come forward and seek help and see us.
Absolutely. We did, as a PCN, have a push, because on our patient record, we do often know people's ethnicity. So we did have a bit of a drive to try to encourage our gentlemen who were Black and Afro-Caribbean ethnic origin to have a PSA test. I think the uptake wasn't bad. So we've got the couple of questions we've got. The question about what was the performance value of 0. It says it was on the slide with the case study in the description of the patient.
So that's performance status. So that means performance status 0 is the WHO classification, which basically highlights how well a patient is. So this patient, performance status 0 means that they were fit and well and athletic. They probably go to the gym more often than I was. So that's good.
Brilliant. Okay. And then there's another question, which is there a known link between prostatitis and prostate cancer? I.e., is someone more likely to get prostate cancer if they've had prostatitis?
No, there is no correlation between UTIs and prostate cancer. Obviously, everything in the prostate is thought to be inflammation related, but someone who's getting a lot of prostatitis, we want to make sure that why are they getting it? Is it down to their general health, or is it because the prostate's big and they're not emptying their bladder, they're holding a bit of urine back, which is acting as a nidus and a focus for more UTIs to brew within? So it's all about evaluating the entire urological tract, because the prostate has such a blessed blood supply. Once patients get prostatitis, there's a risk, if it's not treated appropriately, it becomes chronic and recurrent, and patients have a lot of symptoms with it. So we need to really get to the bottom of where things stand. And one of the indications to offer surgery such as aquablation is in patients who have a lot of urinary tract infections with an enlarged prostate. Because that's medication really doesn't do much. Yeah.
Really helpful to know. Any other questions for Prof. Vasdev? I mean, we were so lucky to have him here this evening. I would take the opportunity to ask. We've got another question. I don't have an own issue myself, but I have several friends between 65 and 75 years of age who are on drugs for an enlarged prostate. Would aquablation be a better solution for them in the future?
Okay, so I'm going to spend about 2-3 minutes, Tara, if that's okay, discussing this as a point. Now, when patients have an enlarged prostate, they are normally given 2 drugs, either together or in a separate form. The first drug is a drug called an alpha blocker. So this basically relaxes the prostate so patients can pee better. The side effects of this drug are that because it relaxes tissue, it also relaxes blood vessels, and there's a risk of patients feeling giddy and dizzy when they have it. And when they ejaculate, semen can go back within the bladder. So they have retrograde ejaculation. The second drug is a drug called finasteride. So this drug is given at a much higher dose than the ones which is advertised online for hair loss and so on. But this is given at a dose of 5 milligrams, which acts on the male hormone within the prostate to make the prostate shrink. Now, The previous traditional data used to suggest that if both these drugs are given together, this is on huge trials which have happened, the chance of needing surgery on the prostate was halved. So there's a 50% drop risk so hence the reason why we have loads of patients, and I'm sure you have loads of patients in your surgery who want repeat prescriptions of these drugs, which keep going on again and again. Now with finasteride, the risk is breast enlargement in men, being tired all the time, and erectile dysfunction. So if patients are having side effects with drugs, which is much more common than reported because men just take it as a part of being, having these side effects. Patients come and see us and say, look, we've been on these drugs, our symptoms are okay, but we are having side effects. We're having ejaculatory issues, we're having breast enlargement, we're having loss of libido, we are having fatigue and tiredness. The good news is once these drugs are stopped, these side effects reverse. So, coming to your question, is aquablation a better solution? It's all about discussing the benefit and risks. If a patient wants to come off these drugs because of side effects, then we can do the operation. If they're coping with the drug all right, it's fine. But as long as their prostates are not massively enlarged, because these drugs work to a certain point and then they don't. So it's all about seeing a specialist and having a discussion.
Thank you. A couple more questions. Does obesity increase the risk of prostate cancer?
It does. So if you look at, I was very fortunate to do my fellowship in Los Angeles, my robotic fellowship, and certainly obesity in the US is a different ball game. Patients whose BMIs are more than 40, they have a higher risk, just like any other malignancy. So they have higher risk of colorectal malignancy and prostate cancer too.
Super. Now, somebody's quite rightly asking a question about the statistics. So the general risk of prostate cancer is 1 in 8. If you took out all of those extra risk groups, the people who were Black with the family history, the breast cancer history, and the I'm not sure if you can take out people over 50, but and so all of those people where their risk was 1 in 4, if you took all of those high risk patients out, do you know what the risk would be for everybody else?
So the risk. So prostate cancer is the commonest solid organ tumor in the UK now, after skin. So it's the commonest cancer in the UK. So it is 1 in 8. That's the population matrix in the normal population. But as you look into different risks that you mentioned, Afro-Caribbean patients, that is 1 in 4. The breast cancer story is fairly new, so we haven't got data to confirm this. But age after 50, the risk goes up.
Okay. Is there a link between prostate cancer and Peyronie's disease?
No, but there is a slight link. Patients with advanced prostate cancer may have erectile dysfunction because the nerves around the prostate get infiltrated. So they may present with erectile dysfunction. So that's where we are. But Peyronie's is not associated with any malignancy. Peyronie's is only associated with Dupuytren contractures in your hand because it's a collagen-based disease. So Peyronie's disease, basically, for those of you who don't know what it is when the penile curvature, the curvature of the penis changes because of thickening and scarring in the 2 tubes that fill up with blood when a man gets an erection. So this is what it is. And when Peyronie's happens, it causes an abnormal bend of the penis. But there was some data which had come out with vasectomy and Peyronie's disease, but there's nothing at all, actually. There is no correlation at all between the two.
Thank you. There is, I'm not sure if your camera's moved because we can only see the very top of your head now.
Sorry.
So that's okay. There's a question here which I think does sound like you've answered it to me, but while we're deciding as a nation if or what form a national screening program would take, would you still support the PSA test?
100%. I think that's the best thing we have at the minute. It gives us a good, I wouldn't use the word great, but I certainly gives a good parameter on the risks involved. We have majority of the patients that I operate on, because I do surgery, are picked up, 50% of them are picked up purely, they'll go and have a blood test done for something. They'll go and have their hypertension blood test done, their diabetic test done, have a PSA level check, which comes back high. So, we are saving a lot of men from cancer because they are having a test done coincidentally for something else on the health screen, etc. So I think it's time we enforce. And I think, your question is very well put. Which is deciding as a nation in the form of a national screening program. I promise you, we're pushing very hard on this. But with the logistics of a screening program, there's a lot that has to be looked at. And sadly, it's down to the economics of putting a screening program out. So the parameters which are used from the WHO for any screening program is how many people do you need to screen to diagnose to save a life? Because prostate cancer in some situations is not aggressive and can be watched very safely. Low-risk prostate cancers don't need any treatment whatsoever. They can be watched because it's such a heterogeneous tumor in which all prostate cancer patients do not need treatment. That is associated with no survival benefit because you're not treating these patients. Till we don't have that long-term data, that's why we want to get to understand that why is it that some patients who have low-risk prostate cancers in the future may transform to develop high. That's why we want a biomarker thrown into the mix. But look, a screening program will come, but I feel it will come at a level when we really are being able to identify risk groups properly. So if you look at the American data, the different data which is available, in the UK, the number needed to screen is about 262 to save one life. Whereas it's a much, much lower number with breast cancer and cervical cancer.
Right.
So I think the number, it's about 85. So you need to screen a lot more men to save a life. But look, this is all down to mathematics.
Yes, and I think there are some economics. But having said that, the PSA test is a lot easier and more accessible, I would suggest, than a mammogram, and probably less cost. It probably costs less to do the test than doing a mammogram does. I think as a GP, we've kind of always thought, well, lots of men have unnecessary treatment and could end up with side effects with, nerve damage and things for cancer they didn't necessarily need treating. But I think things have moved on a lot since then, especially from what you're saying this evening, with MRI scans and with the aquablation. Well, no, that's for but that there are, and with the robotic treatments, that the risks are probably lower than they historically were.
Absolutely. Absolutely. That is the key. So if you compare open prostate or robotic prostate. So the two patients that I've done today will go home tomorrow morning. Whereas with open surgery, they would stay in for about a week. So there's a huge difference with how robotic surgery is transforming. And even with the aqua ablation, if I can do an operation in 2 hours and I can do it in 8 minutes, as a surgeon, ergonomically, I would pretty much tell you which option I would choose. And patients do so much better too, because a quicker operation, safer, using AI, looking at the imaging, preserving the sphincter. There's a lot of positivity with this.
Absolutely. So there is another question which I think is a bit more, almost probably a bit political. Why is there little awareness of prostate cancer when it is the commonest solid organ cancer? I mean, I have to say, one of the reasons that we organised this set of men's health webinars was because we see women a lot. Women are much more inclined to go to the doctor.
Yeah.
We see women when they're having babies, they come for maternity stuff, they come for contraception, they come with their children. It's not to suggest men don't, but we see a lot more women in practice. And I suspect that although there are definitely areas of women's health where we could do better, men's health sometimes, I think, is less on people's radar.
I think they're trying to work on a lot of awareness. Every time you look, there are more campaigns which run. But we always see this, whenever there's a prostate cancer campaign. When Sir Chris Hoy was diagnosed, we saw this massive surge in referrals coming to us. But we want that sustainability in referrals. And I'm sure, you would agree, Dr. Belcher, that you're probably referring more elevated PSAs than ever before to us compared to what it was. So there's a lot that needs to be improved on, but I think we're getting there. We don't have a screening program. Men are certainly coming to us. They go to work and they find out that their friend or a friend of a friend or a cousin or whatever has been diagnosed with prostate cancer. And the first thing they do is, we need to go and get checked out. And that's when we need to have an open door policy to check these men, offer them a PSA, because what happens is, we want them to have proper blood tests done. We don't want them to go and have a rogue PSA level check somewhere, because an accurate blood test really sets the first step of a journey for patients, as against an abnormal blood test, which causes them to have a lot of unnecessary tests done. So I think quality control with PSA is very, very important via your GP. Instead of ordering a kit online and sending your blood sample away, all that is available. But, the accuracy of an NHS blood test with the regulation is very important. We see patients who've had these blood tests done. I saw a guy who had a blood test done. His PSA was 40. I repeated it at the list. It was 1. So you just wonder what the quality control is with some of these blood tests available online.
Absolutely. I think certainly when we have patients who ask us if they can have a PSA test, we actually have been directing them to the Prostate Cancer UK website to see whether they flag as high risk, because some younger men who are maybe, in their 30s or 40s who have heard about Chris Hoy but don't have any family history, they haven't got the ethnic origin, what have you, that can be quite helpful. And essentially, if you're over 50, it will say, yes, ask your GP for a PSA test. And we're more than happy to do those. The reason I was asking about how often to do them is because sometimes people are asking for them every year. And I think if you've had a nice normal test,
I'm happy to send you. I'm happy to send you a guideline that I've sort of written up on this. I can bring it to you.
That would be great.
Tara,
so we've got.
I think just checking with Prof. Are you happy to stay on, Prof? Have you got patients
for another
waiting?
3-4 minutes? I have a couple of patients, but it's fine. If you wrap up in 5 minutes,
we wouldn't be here beyond 1:30, I don't think. But we've only got 2 more questions. Is there a downside to asking my GP to do a PSA test? I'm 71.
Not at all. You can have a blood test done.
Absolutely. And then is there, somebody said it, I was advised it was not necessarily as I was not high risk. I'm obviously, for an individual, it's hard to say.
Yeah.
If you've had a PSA in the last 3 or 4 years that was less than 1, and you're 71, that would be a reason to not do another one, from what Professor Vasdev said.
Yeah, exactly. But if you have it, does the question say this gentleman had a PSA done?
He says he hasn't had a test. So
he should have one done,
Yeah.
He's 71. You should have a baseline. You should have a baseline PSA, Mr. Murphy.
And then our final question, is it likely that aquablation becomes the default procedure in the next 5 to 10 years?
100%. As a matter of fact, I was in New York at Mount Sinai last month, and I was amazed to see that aquablation is the fastest growing robot in the world at the minute. And, I think with NHS commissioning happening, we will see more and more aquablation centers come up. It probably will replace the standard operating for a BPH, yes, 100%.
Thank you. Thank you so much, Professor Vasdev. Honestly, I can't thank you enough. It's so
Pleasure.
wonderful to have such a knowledgeable speaker. Brilliant, and really great for all of our audience who've been able to hear from somebody who really knows all the ins and outs and nuts and bolts of this kind of all of these prostate problems. Our next webinar is on Tuesday, the 12th of February, and it should be from 6 till 7, unless I mess that up. And it will be about musculoskeletal issues and how they relate to men. So huge thanks again, and thank you, Jackie, for helping to organise that, and thank you to everybody for attending.
Thank you very much for the opportunity. Thank you, Jackie.
Thank you.
Tara. Bye-bye.
Thanks, Prof, for that brilliant presentation. Thanks,
Thank
Tara.
you.